My name is Kedar Prasad Baral, Professor of Public Health at Patton Academy of Health Sciences. This presentation was made at the Rockefeller Bellagio Center on 30th August 2017. A conference was held on punching above their weight. I just would like to present here that how in last 25 years from 1991 to date, what are the health sector achievement in this country. In 1991, our infant mortality rate was 97, 98. In 2016 is 32. The reduction is more than 2.5, more than 2.5 percent point, and neonatal mortality was in 96, 50. Now it's 21. Maternal mortality was 750. Now it's 258. Total fertility rate in 1991 was 5.6, and now it's 2.3. Life expectancy in 1991 was 54. Now it's 17. And there is other indicator also has changed. It shows that there is a lot of achievement in the health sector in Nepal. Okay, let me little bit give the context. What's from 1991 to date. The history of we have till 1991 we had an autocratic regime. 91 parliamentary democracy was established. Now Nepal is a federal democratic republic country, and in 1991 we have a new national health policy. That policy wrote the path of a systematic effort to establish a health system which with the rapid expansion of health facility, with the establishment of what we call health posts, sub-health posts, and different district hospital. In the meantime, we had an armed conflict from mid-90s, and it's ended in 2003 through a peace accord. Along with others, topography is a challenge for the access of the service in this country. This achievement we'll have to see in this context. What has worked then? What was something unique or something different in Nepal? Along with other, community health system contributed probably the most from Nepal's achievement. And what is this? The late 80s, precisely 1988, female community health volunteer system started in Nepal, and this program, the female community health program, continually strengthened as of today, and there are 51 plus thousand in number. There is a law establishment of not only health facility but outreach system like PSC outreach more than around 13,000, and EPI outreach are more than 16,000, and health budget is not much. It ranges from 3 to 7.2% of total national budget depending upon different year, but the majority of our budget is spent on public health sector. Okay, let me take you through some of the event that takes place from 1991 and later. In Nepal, there is a series of study done in Nepal, and many of the program was piloted and scale up high impact intervention. I would like to give two examples. One is vitamin A program study was done in Nepal along with other countries, and that program started implementation and scale up throughout the country. The other program was integrated management of childhood illness, and that was a lot of pilot study were done, and integrated management of childhood illness program were adopted in Nepal in a way to make it as a community-based program. And I will give two examples. And this program the characteristic of program was community-based. This program was delivered by the female community health volunteer. And if you talk about the public health intervention, there are three very, very important issue will have to be examined. One would be who is going to provide, where they will be providing, what is we call platform, and what are the package, whether that intervention is high impact intervention or not, and how it packages. In Nepal, our public health leader actually, done a wonderful job uh, to pick up high tested intervention, package in a way, delivered at the community level through a system of female community health volunteer. Let me just take through, there are program example I've been talking, there are a lot of policy like 1997, there was a safe motherhood policy, long-term health policy, it came in 97 up to 2017, health sector-wise approach started in 2004, we started sector-wise program, the program 2005, 2004, a systematic effort. We had a conflict and we had a kind of policies and document like conflict and health in Nepal, action for peace building. There was conscious effort from the public health sector to address the need and to reach the people in this country. I just would like to give you why this community-based program. See this house, how it's isolated, probably difficult to reach. Even in the trail, even in monsoon, it would be impossible outsider to reach there. And this is a real photograph of people are taking a pregnant woman to the health facility for delivery. This is another photograph of referred patient. They are traveling to an airstrip to go to a better place. See one of the house, a family living below poverty line. And this is another example of the terrain of this country, the geographical difficulties. And see this two picture of children. These are both from Nepal. And these two group of children need intervention. Probably the reaching strategy should be different. If we have a same reaching strategy, if we are expecting them to come to a facility of both group, that will not work. And these few pictures, I am just trying to exemplify the uniqueness of nation and the program. And this is a female community health volunteer. They are together. Actually, there is one of the men, standing person is physician. They are visiting. You can see the confidence of these women. They are empowered. These are female community health volunteer with their dress and sari. The other is, we have a national female community health volunteer day. We celebrate annually throughout the country. This is one of the national event in health sector. With this, with the achievement, with the constraint, with the policy and program, what are the characteristics of the community-based program in this country? The program was developed on success and the lesson learned. That's I really would like to emphasize. And these programs are nationally supported. Everybody talks about the same program because there is a ownership. The system own the program itself. It's community based. As community characteristics changes, it's reflected on FCSB. For example, literacy. 25 years ago, probably in some of the districts where I have worked, the FCSB literacy rate was 10%. If we go in the same district, the literacy goes up probably between 30 and 40%. Because things have, as things change at the community, because they are community representative, whatever happened at the community level, that reflected them, and things have changed. They are starting taking more and more responsibility. But it started with a family planning and then added with vitamin A, and then the treatment of pneumonia, and then deworming, and then polio program. It's packaged in a way and develop and train and skill to deliver at the community level, and they are integral part of our national development process. They are part of the water and sanitation program. They are part of the forestry group activities. They are part of the agriculture processes. That's how it's supported. It's been built on, so that it also addresses some of the determinant of health factor as well, and reach across all level of social gradient. I really would like to emphasize that the program that we deliver through a mechanism of community-based intervention, that the gradient difference between the wealth quintile or different ethnicity is very, very minimal. If you see the national statistic, it's been very little differences. That means the program that delivered by the female community health volunteer is universal, which is extremely important to have a public health impact at the national level. And they are well established informal leader. Now they have started taking formal position also. Finally, I have shown that there are challenges in this country. It's not that if we want to address the equity, for peace and stability, we need to work on justice. I really would like to emphasize that. And there are upcoming challenges like non-communicable diseases, outbreak, disaster. Unless we draw lesson from the previous program that has community-based one, we won't be able to, there will be a social gradient. If we don't want, then we need to design in a way that should be a community-based. Access should not be an issue, so that we can create a enabling environment for the peace and justice to do for everybody. And this challenge we need to address this very, very, very carefully, so that our pace of improvement in the health sector would maintain, and will be able to address the upcoming challenges that we have. Some of the challenges we have expected, many of them are unexpected. We don't know as yet, but we need to prepare in a way that we learned in the past 25 years. Finally, showing a village. We need to keep in mind while designing a policy and the intervention that we need to view this, we need to keep this in mind, so that we'll continue to move as in the past. The remarkable improvement that we have made, we need to address, we need to keep in mind, so that we'll reach all people of social strata or geographical location or any barrier or any any kind of differences. With this, I would like to thank you very much.